Good evening, everyone. I'd like to acknowledge the local custodians of land on which we meet this evening. I'm sitting on Darkinjung land in the beautiful Avoca Beach and honour elders past, present and emerging. I'm Melissa Wilkinson from the Hunter New England Central Coast Primary Health Network. Welcome, everybody. I hope you're all staying safe and dry wherever you're tuning in from tonight. Just some little bit of housekeeping. There will be a QR code tonight for the survey, and that needs to be completed, especially if you would like your RACGP points and you're a GP or ACRM. So please make sure you do that, and they'll be at the end of the slides. We will have a question time. I can encourage you to pop your questions into the chat box or the questions box, and we'll monitor those and refer to those as well later on in the session. We are being recorded. However, the recording will only be live for 2 weeks on our website, and then it won't be up after that. So if you're going to watch it after the event, you've got 2 weeks to do so. I'm going to hand over now. It gives me great pleasure to welcome Narelle Williamson. Thank you for being with us tonight, Narelle. And before I do so, I'm just going to also mention that at the end of this session, if you are a GP and you require ACRM or RACGP points, please complete the little survey at the end that's going to pop up, and it's going to ask you for your name and your number, and that way you'll be able to upload you for your points for tonight. So over to you, Narelle. Thank you.
Thank you, Mel. Hi, everyone. I echo Mel's thoughts in hoping that you're all safe up there in New South Wales after all of COVID that we've had to be put through. Now you guys have got floods, and I know they're a little worse higher up in the state than you, but I hope you all can stay safe and that you don't get too much rain. Alrighty, so tonight is a great topic, Mel and I were just saying, and it's only an hour, but we cover asthma and COPD overlap. Obviously, COPD and asthma are two completely different diseases, but there is a disease called asthma and COPD overlap. So we developed this webinar when we could no longer travel and do our face-to-face workshops. And it's been one of our most popular webinars, actually. So what we'll look at tonight, or our learning objectives, are to describe how to access the COPDX and asthma management guidelines. We will identify the differential clinical features between asthma and COPD individually, and we'll summarise the current guidelines for medication management, and there has been an update about 12 months ago, so that'll be very interesting. And we'll also summarise the utmost importance of written asthma action plans. For those of you who haven't, I'm sure you all have seen it, but this is our website for our Australian Asthma Handbook. So our handbook is actually going through a minor update at the moment. So version 2.2 is due for release in about 2 weeks. Considering it's a minor version, there's 102 pages of updates, which I've been trawling through, updating each and every one of our presentations, which has been a task. But the handbook is updated regularly. Guidelines are written by a committee of respiratory experts. But the website is really easy to use. Just use the search function there and you can find out absolutely anything and everything about acute asthma, severe asthma, pediatric, adult asthma, etc., etc., etc. And this is our National Asthma Council website, which you all may have seen as well. This is where you can jump online and order any of our resources. We are back in the office now as of this week, so just jump online and order them and we can send them out to you. This website is the Lung Foundation Australia. They're actually in the same office as us. Lung Foundation Australia deal a bit more in COPD and cystic fibrosis and lung cancer. Obviously, the National Asthma Council is about asthma and a little bit about COPD, but we work very closely with the Lung Foundation Australia, and this is their website. And they have COPDX guidelines. So much like our Asthma Handbook, the COPDX guidelines are the Lung Foundation's Bible, like the handbook is our Bible. So similarly to our websites, you can jump on either of those websites. The guidelines are evidence-based practical recommendations, just like ours at the National Asthma Council. So let's just run through a few stats now for asthma and COPD, but we'll start with asthma. So over 2.7 million Australians have asthma, which is approximately 1 in 9, which is high by international standards. And since 2001, there's been a decline in children and young adults with asthma. but it's been stable in adults over 35 years. Asthma is more common in boys than girls, but after adolescence, it's more common in women. And unfortunately, our death stats haven't really decreased in the past few years, so we've got a bit of work to do. But in 2020, there were 417 people passing away with asthma. In 2019, it was 421. And I think in 2018, it was high 300s. And in 2020 and 2019, there were about 130 more females who passed away from asthma than males. So it was 274, I'm just looking down at my notes here, 274 females and 143 males. So 50% of people with asthma over 75 years have not been diagnosed by a doctor. We find that neighbours tell them or relatives tell them, oh, you've got asthma. Our SABA medications, our short-acting beta agonists like Ventolin and Bricanol, they're available over the counter and they're relatively inexpensive, so they're much more easily accessible than preventer medications. And a lot of these people haven't had the formal diagnosis, including spirometry or lung function testing to confirm diagnosis. So that's pretty scary when you think 50% of people have not been diagnosed by a doctor. And reports from around the world show that 25 to 35% of people with a diagnosis of asthma in primary care may not actually have asthma. So a few stats about COPD now, and these come from the Lung Foundation, and these were from 2020. So 7.5% of Australians aged 40 or over have symptomatic COPD, even though half of them are undiagnosed. And of those with COPD, 3 in 4 people aren't aware. Their symptoms are either mistaken for asthma, old age, or lack of fitness, and people are unaware that it's a slow progressive disease. So 20 to 30% of patients approximately who are given a clinical diagnosis of COPD do not meet the diagnostic criteria. In 2018, COPD was the 5th leading cause of death with 7,113 people dying. And it's worth noting that COPD is more likely to be reported as an associated cause of death rather than the underlying cause of death. So remember that asthma is a chronic lung disease and it can be controlled, but unfortunately, as yet, it can't be cured. Asthma is defined in clinical practice by the presence of both of the following. So there's excessive variation in lung function and variable symptoms, which will be reported to us by the patient. And associated features of other allergic conditions such as rhinitis and eczema may be present, as well as family history, childhood asthma. Their symptoms could be rapidly relieved by a bronchodilator, eosinophilia, or raised blood IgE. And with COPD, well, it's a common, preventable and treatable disease characterised by persistent respiratory symptoms and airflow limitation due to airway and or alveolar abnormalities. So the chronic airflow limitation is caused by a mixture of small airways disease, such as obstructive bronchitis, and parenchymal destruction, so the emphysema. COPD is not fully reversible and airflow limitation is usually progressive. And the irreversible component of airflow limitation is the end result of that inflammation, fibrosis, and the eventual remodeling of peripheral airways. So the diagnosis can be mild, moderate, or severe COPD, and that's based on the patient's spirometry results. In clinical practice, diagnosis is normally based on symptoms of exertional breathlessness, cough, and sputum, their history of smoking or exposure to other noxious agents, FEV1 over FVC, their spirometry terms, don't get too worried about those if it's less than 0.7% post-Ventolin. And sometimes further investigations may be required, for example, for alpha-1 antitrypsin deficiency. That's a rare genetic condition that predisposes to lung disease such as emphysema or bronchiectasis and may initially present with adult onset respiratory symptoms and airflow limitation. So we need to remember that asthma and COPD Both diseases and patients with both diseases or asthma COPD overlap. They require ongoing education. It's so important for the disease outcome that they're not just seen once or twice throughout the disease lifetime. Ongoing education is so, so important, and you'll hear me reiterate that a few times tonight. The difference with patient-centered care being with asthmatic patients, they often present to hospital or primary care acutely ill. They'll accept immediate treatment. They will have relief of symptoms with treatment most likely. They may be reluctant for ongoing management and therefore need support to be educated and to maintain their own management for that optimal asthma control. They may not understand the disease process or the future risks, and they may not have identified their triggers that trigger their asthma. And the treatment aim is to restore lung function. Whereas our patients with COPD, they present or are diagnosed at different stages of the disease process. 10% are at risk of dying post an exacerbation that requires them to be hospitalised. Some are reluctant to accept the diagnosis or are quite frightened once they understand the progressive nature of the disease. And patients may feel a sense of guilt if smoking has caused the disease. And the treatment aim is to prevent further deterioration of lung function. But as I said, this is a progressive disease, so it can be quite scary. So looking at asthma COPD overlap now, and approximately 20% of patients with obstructive lung disease have features of both asthma and COPD. And asthma COPD overlap is not a single well-defined disease, but it's likely to have many underlying causes. And a specific definition of asthma COPD therefore can't really be developed and hasn't been developed until we get more evidence about its clinical phenotypes and underlying mechanisms. But overlap can develop in smokers, it can develop in ex-smokers or in non-smokers. And asthma COPD overlap is now recognised as an important clinical problem, and primary care was pivotal in identifying those with overlap, and it's recognised now that appropriately trained primary care professionals, like all of us here tonight, can identify those who may have asthma COPD overlap and provide that initial therapy and specific specialist care as required. So people with asthma COPD overlap often have poorer disease outcomes than those with asthma or COPD alone. And such things are more symptoms, lower quality of life, more hospitalisations, more comorbidities, increased mortality, higher healthcare costs, greater prevalence of insomnia, and more exacerbations. So this is the information sheet regarding asthma COPD, developed by both of the National Asthma Council and the Lung Foundation. So it distinguishes between typical asthma and typical COPD, and it is pretty straightforward. However, it can be difficult to distinguish COPD from asthma in adults who have features of both conditions. And this is not a definition, but a description for clinical use. Asthma COPD overlap is characterised by persistent airflow limitation with several features usually associated with asthma and several features associated with COPD. In clinical practice, asthma COPD overlap is identified by the features it shares with both. And as I said, as asthma COPD overlap includes several different clinical phenotypes, there is likely to be several underlying mechanisms. Now, this paper is still available. It's a really useful paper to hand to patients. So jump on board our National Asthma Council website or the Lung Foundation Australia website, and you'll be able to have those sent out to you. They're really great papers and very easy to understand. So looking at the diagnosis of asthma COPD overlap, it's based on symptoms and an assessment of lung function and airway inflammation. So when we look at a detailed medical history, we would be looking at whether the patient has a chronic or recurrent cough, how much sputum production they have, the amount of dyspnea, wheezing, whether they have recurring acute lower respiratory tract infections, their exposure to tobacco smoke and other airborne pollutants, or previous doctor-diagnosed asthma or COPD. Then we would also include in the diagnosis a physical examination, of course, and this could be normal, or there could be evidence of hyperinflation, or that you might in fact find that there's abnormal auscultation with a stethoscope. Spirometry, as always, plays a pivotal part in the diagnosis and monitoring, but at the moment we're talking about diagnosis. So peak flow is no substitute for spirometry. Spirometry must be performed in the diagnosis of asthma or COPD or overlap. And of course, pre and post bronchodilator results or tests should be performed. There's no point just doing pre-Ventolin or post-Ventolin. Everything needs to be performed. You need to allow a good half hour to perform a good solid spirometry. When we look at radiology tests, they're not routine for asthma, but a chest X-ray or CT scans or an MRI may identify an alternative diagnosis. So people with asthma COPD may have airway eosinophilia, neutrophilia, or a mixed pattern of airway inflammation. And we would suspect coexistence in middle-aged or older patients with a history of cigarette smoke and diagnosis made before the age of 40. So that's for overlap. It's before the age of 40. This slide indicates, it's a really good one, indicates the benefits of spirometry in the diagnosis of asthma COPD overlap. And it shows that early spirometry testing will detect the changes in lung function around 40 years of age, whilst other indicators of COPD, such as the symptoms, arterial blood gases and chest X-ray, they remain within normal ranges until much older. So it's not until about 50 years of age and older that symptoms, blood gases and X-ray are going to show any signs of overlap. It just shows that the spirometry will pick it up a lot earlier. And people tend to, looking at the symptoms there, people tend to tolerate the cough and sputum until they become breathless, and they never want to attribute this to a disease or a diagnosis. But then the COPD component may have progressed to significant loss of lung function by the time they go to their doctor with just symptoms. So that's where spirometry can really play a huge part in diagnosis. So as we know, the diagnosis of obstructive lung disease relies on spirometry, and as I said, pre and post spirometry is required. And this slide shows examples of spirometry tracings in a normal or healthy airway, in an asthmatic airway, in an airway of a patient who's suffering from COPD, and then in an asthma COPD overlap airway. So the dashed line indicates spirometry pre-bronchodilator, so pre-Ventolin, and the red line indicates the results post-Ventolin or post-bronchodilator. Now, when we do spirometry, if we say a patient's airways or their condition is reversible, for example, in asthma, because it is reversible, that can be defined as an FEV1 increase of over 12% and more than 200 mils following Ventolin. So you can see in that asthmatic airway, the dashed line, meaning before Ventolin, the red line after Ventolin, what they can blow out forcefully in the first second. If there's a greater than 12% increase in 200 mils, we know that it's asthma because that's reversible. So while some reversibility of airflow limitation with Ventolin may be found in patients with COPD alone, an FEV1 increase of more than 400 mils suggests coexisting asthma. So you can see in the bottom right-hand graph where the asterisk is there, that indicates a difference pre and post Ventolin of over 400 mils. So that's what helps us to distinguish the difference between asthma COPD overlap versus just asthma or versus just COPD. You can see that huge change in results before and after Ventolin. And this is a really good table. I'll run through it because it's what I used to use when I first started educating in respiratory clinics. I always referred to this table because it just explains things very clearly and the exact differences between asthma and COPD. So with asthma, the age of onset will be before 20 years generally. With COPD, it will be after 40. Pattern of symptoms with asthma, There's a variation in symptoms over minutes, hours, or days. Symptoms are worse during the night or early in the morning, and symptoms are most often triggered by exercise, laughter, dust, exposure to allergens. In COPD, however, there's persistent symptoms despite treatment. The shortness of breath is usually activity related and usually resolves with rest. And there's chronic cough and sputum unrelated to any triggers like there are with asthma. When we're looking at lung function, in an asthmatic patient, they will show variable airflow limitation, whereas with COPD patients, they will have persistent airflow limitation. Lung function between symptoms or between flare-ups is usually normal lung function for an asthmatic patient when they're not having an exacerbation, whereas for COPD, their lung function will still be abnormal. So it's persistent, as I said, and consistent. When we look at past history or family history, with asthma, there's usually a previous diagnosis of asthma or a family history of asthma and or other allergic conditions. And when we look at family history, we think first degree relatives. There's usually a smoking history of nothing, no smoking history, or to less than 15 pack years. I can explain pack years to you in a moment. And with COPD, the past history or family history is usually previous diagnosis, heavy exposure to risk factor tobacco smoke or other noxious agents. Now, when we're working out pack year history, this is what you will need to put into your spirometer devices. Pack year history is the number of cigarettes that a person has smoked per day, multiplied by the number of years that they have smoked, divided by 20. And with smokers who have been smoking cigarettes for 20 odd years or so, they've got a much higher pack history than someone with asthma who's never smoked or has only been exposed to passive smoking. And then finally, looking at the time course for the characteristics between asthma and COPD. With asthma, there's generally no worsening of symptoms over time, but it is seasonal for a lot of people. And there's rapid response to bronchodilator or to inhaled corticosteroids over weeks. Whereas with COPD, symptoms slowly worsen over time, and rapid-acting bronchodilators such as Ventolin provide only limited relief. So if you want to get a copy of that chart, it is available on both the NAC website and the Asthma Handbook website, or you can ask Mel and I can send it out to you. But it's a good one to have laminated in your workplace. So management of asthma COPD overlap. So it's always bronchodilators for symptom control. If there's any features of asthma, we would prescribe regular low to moderate dose of inhaled corticosteroids, and depending on the symptoms, we would consider adding to the inhaled corticosteroid a long-acting beta-2 agonist or a long-acting muscarinic antagonist, LABAs and LAMAs. We have a lot of acronyms in the respiratory world, or a LABA-LAMA combination. And I'll get to those shortly. I'll elaborate on the medications. So all patients should have a written asthma or written COPD action plan, and it should be updated regularly every 6 to 12 months, but definitely at least once every 12 months if they haven't had a flare-up or an exacerbation or a hospitalisation. Management, of course, requires monitoring and treating respiratory tract infections, and it also, of course, includes self-management support and education. So we want to manage asthma COPD overlap as a chronic disease because it is, and it needs ongoing care. We need to address smoking cessation and eliminate passive exposure if that's relevant to our patient. Smoking cessation is the most important intervention to prevent worsening of COPD. We need to identify triggers, including avoidance strategies for those triggers. And we need to discuss vaccination with our patients, particularly against influenza and pneumonia. And vaccinations should be actively promoted in these patients, and also in the updated guidelines that are due to be released at the end of this month. COVID vaccination, of course, and pertussis vaccination has actually been added to the handbook too. So although pertussis infection is generally not too problematic in adults, it can be associated with worse symptoms and severe disease in people with just asthma or just COPD, but certainly with overlap. We would also want to discuss pulmonary rehab, including self-management education, healthy, well-balanced diet, exercise regime and activity levels, and stress management. Okay, let's move on to the dreaded for our patients, tobacco smoking topic. So tobacco smoking. Smoking is the largest single preventable cause of death and disease, as I'm sure you're all aware. And passive smoking can lead to increased risk of heart disease, asthma, COPD, SIDS, and some cancers, of course. And smoking in pregnancy increases health risks to both the mother and the child. Smoking worsens asthma and or COPD and reduces effectiveness of our inhaled medications. And if a patient has greater than 10 pack years of smoking, well, it definitely will mean a great effect on their lungs. I've just got some stats here that in the last decade, we've found that 14.5% of adults aged 18 years and over back in 2014-15 were daily smokers. And that was down from 2011, where there was 16.5% of smokers. So that trend is decreasing, which is good. Men have been consistently more likely to smoke daily than women. It's about a 27% of men compared with 20% of women who were smoking back in the 1990s. And by 2014-15, it was 16.9% of males and 12.1% of females. So I think the trend is definitely going down, and similarly for our teenagers, which is good news. This graph is also a great graph, and I find in my respiratory clinics, it's very good to show this graph to our smoking patients. It demonstrates how smoking affects lung function, but perhaps more importantly, how smoking cessation reduces the rate of decline in lung function. So you can see, and we know, that lung function falls gradually over a lifetime, as seen by the solid blue curve at the top of the graph. A person who smokes regularly from the age of 25 is susceptible to the effects of smoking, and lung function declines steadily, as shown by that green line there. So you can see the difference in a person who has regularly smoked, how their lung function declines pretty quickly compared to those of us who perhaps have never smoked, with the blue line at the top. So onset of symptoms often doesn't appear until there is a significant decline in lung function, and smoking, as we know, causes irreversible obstructive changes. So if a smoker stops smoking, he will not recover that lung function. However, the average loss of lung function will revert to normal, as shown by those blue dashed lines there. So you can see if a patient was to stop smoking at 45 years, he started at 25 but stops at 45, he was on that green line decline there, but once he stops smoking, he moves back out to the normal susceptible to smoke effects. Similarly, if a patient begins smoking at 25 and stops smoking at 65, their lung function does not decline at such a significant rate. So I find that, as I said, that's a very good graph to show patients, and they can see that, you know, there always is a good time to stop smoking. When we discuss quitting with our patients, in summary, I guess stopping smoking reduces the incidence and progression of lung disease, including chronic bronchitis and emphysema. And smokers who quit at age 50, for example, halve their risk of death caused by smoking. Quitting by age 30 avoids almost all of the excess risk associated with smoking. And one of our favourite sayings here at the NAC is that it's far better to try and try again than to fail to try again. I found with patients in my respiratory clinics not to go too hard on them. You know, if you say you need to give up smoking, they're more than likely either going to walk out of the consult or be just as determined to continue smoking. Whereas if we just do it gradually, I've had a bit of success, fortunately, over the time. Not 100% success, but I find that pushing them too hard doesn't always work. So I just like to pause here and see if there's any questions. Mel, you might like to read out any questions if there's been any typed into the chat box.
Sure, I'm just having a look, Narelle, and there's nothing in the questions box. So I'm just going to check the chat box. Obviously, you're covering everything, which is awesome. No, nothing's come through yet. So if anyone has them, any questions, please place them in the questions box. We'll just give you a minute or so to do so, and if not, then towards the end of the session.
You might have some questions at the end. We're going to get into the nitty-gritty of the medications now, so a bit more intense. Have a sip of my tea while we're waiting for it.
Yeah. Nothing's coming through so far. Oh, we've got one now. Very informative, thank you. And we've got lots of positive comments saying that the content has been great. So that's lovely. And I've just got one come through now. Are we back doing spirometry in general practice?
I'm going to get to that very shortly. If you're happy to wait till closer to the end, yes, we are going to get to that.
Fantastic.
Most common question we get asked at the moment.
I'm sure it is. I'm sure it is.
You and I were just discussing that before we came on, weren't we, Mel, about the importance?
Yes, we were. Yes, so it's very timely. Okay, that's it so far, Narelle. So I'll hand back over to you, and we'll have a look again for questions at the end.
Thanks, Mel. All right, well, you may have already seen this medications chart. It was released in November 2020, so not so new anymore. And again, like a few of our other resources, that this is being updated and should be available at the end of March. This chart, when it was released at the end of 2020, was fantastic and is still fantastic because of the introduction down in the bottom left-hand corner of the scan function, which we're all used to now, aren't we, with COVID? That scan function takes you to the NAC's video library, and that's where myself and a few of our other educators educate on film how to use each and every device that you see on this medication chart and more. So it's a really valuable library, our how-to library, because as much as we can teach our patients in consultations, or hopefully our pharmacists are teaching our patients when they pick up their devices from the pharmacy how to use them. And of course, we've got the leaflet inside the box of how to use them, but there's nothing quite like personal demonstration. So a lot of patients do need to refer back to the how-to video libraries. So that's a really good resource. In the new chart that's about to be released, there's probably 2 or 3 medications on this chart that have been removed and 3 or 4 that have been added. It's getting busier and busier, this chart, squashed in. I think when I started 15 years ago in respiratory, there were maybe 10 medications on the chart, as I'm sure some of you remember. But we always want to minimise a patient's number of medication devices, of course. We don't want a patient to be using, for example, a Ventolin MDI and then a Seretide Accuhaler or an Ellipta. As much as we can, try and keep your patients on the same device. It's much easier for them to remember, and just overall, just easier for the patient. It avoids confusion about inhaler technique. So keep an eye out for our new chart. It'll be on our website come the first week of April, I'm hoping. It's been a bit of a delay with COVID, but we're getting there. So we're going to run through a big section now to finish off our second half on medications for asthma, medications for COPD, and for overlap. And of course, you all know about relievers, our short-acting beta-2 agonists, or our SABAs as we call them, our bronchodilators. So our short-acting beta-2 agonists can be used for short-term symptom relief in asthma, COPD, and overlap. And we would always want to check inhaler technique, and where possible, in fact, I should change that wording, always should be used with a spacer. I understand that there's moments when people won't have their spacer with them, but spacers come in all different shapes and sizes now, that they can come in cardboard collapsible spacers. You know, we don't all have to use the big Breathatech football size spacer anymore. We can, volumatic they're called. So really everyone should be using a spacer with their short-acting beta agonist. However, the recent guidelines, the most updated guidelines for the handbook back in 2020 September, version 2.1 that is, they recommend against treating asthma in adults with SABA alone. So once upon a time where we might do a trial for a new asthma patient, we might trial them on Ventolin or Bricanol, or back in the day Atrovent potentially. We're not recommending that anymore. Almost everyone who's diagnosed with asthma, even mild asthma, now needs to be started on an inhaled corticosteroid. However, there obviously still is place for the reliever medication because it works so quickly, works within 5 minutes, and there's immediate relief of symptoms that the patient can feel. So the asthma guidelines generally recommend inhaled corticosteroids now for most adults, and recommend against long-acting beta-2 agonists without corticosteroid therapy, whereas the COPD guidelines recommend a long-acting beta-2 agonist as an initial treatment and combination inhaled corticosteroids. When we're looking at our long-acting beta-2 agonists, they're similar to our short-acting, but as the name suggests, they're long-acting. So they tend to have a 12-hour time of effectiveness, if you like. So they produce prolonged bronchodilation, whereas the SABAs, the short-acting, produce bronchodilation for 3 to 4 hours. These long-acting ones usually last up to 12 hours. So you might recognize some of the names there: Formoterol, which is in Oxys, Salmeterol, which is in Ceravent, and Indacapterol, which is a relatively new one, which is on Breezhaler. So as I said, these long-acting beta-2 agonists shouldn't be used in people with asthma or asthma COPD overlap unless they are also taking an inhaled corticosteroid. It can get confusing, I know. Long-acting muscarinic antagonists, or our LAMAs. So similarly, they're like long-acting bronchodilators. We have tiotropium, which one of the new medications which is amazing for COPD is the Spiriva HandiHaler or Spiriva Respimat. We also have a new drug called Brolta-Sonda. Then we have the C-Bree Breezhaler, that's a tongue twister, Umeclinidium in Cruisolipta, or Aclinidium, which is the Britaris Genuaire. So the top three are once daily maintenance. The Britaris is twice daily maintenance. And similarly to the LABAs, our LAMAs, our long-acting muscarinic antagonists, shouldn't be used in people with asthma or overlap unless they are also taking an ICS. So we've got our LAMAs. Our LAMAs were formerly known as anticholinergics. You may remember that terminology, but not commonly known as those anymore. So we've got our relievers, our inhaled corticosteroids, our long-acting relievers. Then we have, just to add a bit of confusion, our combination therapies. So there's different types of combination therapies. You can have LABAs and LAMAs together. As the name suggests, a single device consisting of a long-acting beta-2 agonist and a long-acting muscarinic antagonist. You may have heard of Anoro-Ellipta, Ultibro Breezhaler, Spiolto Respimat, or Brimica Genuaire. They're the most common LABA-LAMAs, and they're used only for COPD. Another type of combination therapy is our ICS LABAs. So ICS stands for inhaled corticosteroid, so our preventers, and a long-acting beta-2 agonist. So these are some of the most common combination therapies, and you will have all heard of Seretide and Symbicort, and what else is there? Foster. So Foster, the beclometazone, halfway to a little bit towards the bottom, beclometazone Formoterol is Foster. It's a very, well, it's an up-and-coming drug. It's definitely going to be used alongside Symbicort for our mild asthmatics, where we want them to be starting on an inhaled corticosteroid, not just a bronchodilator such as Ventolin. So you'll see Foster mentioned a lot in the future. So they're all our current common combinations. They can all be found in a nice little chart on the NAC website and also in the handbook website, and also on the medication charts, obviously. And then there's one down the bottom called mometasone indicatorol. That's Atectura. It's just come onto the market, and we're actually waiting to hear if it will be PBS listed for asthma. At the moment it is for COPD, but not for asthma. Of course, with these drugs, we want to warn our patients of the side effects. So due to the inhaled corticosteroids, they may experience a bit of dysphonia or oral thrush, so they always need to rinse and gargle. I just like to point out that with the LABAs, the combination of salmeterol and fluticasone, for example, the Seretide, it's not been trialled in children under 4 with the LABA combination. So Seretide shouldn't be prescribed for children under 4 or under 5. It's prescribed from 5 and above is what I'm trying to say. So yeah, it just has not been trialled yet. Symbicort, similarly, hasn't been trialled in children, but that age group is for under 12. So Symbicort 12 and over, Seretide 5 and over. Foster is 18 and over at the moment, but watch this space. Then, not only do we have the double combinations, but we have triple combinations. So this is where we have a combination of the inhaled corticosteroid, the long-acting muscarinic antagonist, and the long-acting beta agonist. And at the moment, we have Trilogy Ellipta, PBS approved for COPD. PBS or PBAC were reviewing a few different drugs on Tuesday, and we're waiting for notification, but we're hoping Trilogy will be PBS listed for asthma as well. So it contains fluticasone, umeclinidium, and vilanterol. It's a once daily maintenance for those patients who suffer from moderate to severe COPD. So that is where their FEV1 is less than 50% predicted, and that they have had 2 or more exacerbations in the last 12 months. Trilogy Ellipta is not recommended for initial treatment for COPD. We would always want to try the patient on the individual drugs before starting them on a triple combination, but certainly we find that a lot of patients before too long are needing a triple combination. Another type of triple combination is budesonide, glycopronium, and formoterol, or the Breztri Aerosphere, which you can see there in the picture, and Trimbo, the beclomethasone, glycopronium, and formoterol. Trimbo is being reviewed by PBS as well as at the moment, and we're hoping that it will certainly be PBS listed for asthma. I'm waiting to hear in the next few days. And it was listed in June last year for COPD, for moderate to severe COPD patients. 2 puffs, twice daily maintenance dosing, 18 years and over, for both the Trimbo and the Breztri. All right, now that I've completely bombarded you with medications, let's talk about written asthma action plans, or written COPD action plans. So an individualized asthma or COPD written action plan, I should say, should be developed for every single patient. They need to be individualized, personalized. They must be in a language that the patient understands. I know goes without saying, but you'd be surprised. They provide advice about modification of treatment according to the patient's symptoms. They also list emergency steps and useful contact numbers for the patient if they are experiencing an exacerbation. A useful resource, and I'm about to show you a couple of different options, is the Asthma Handbook website and the Lung Foundation website. And I'm happy to say that written action plans, both for COPD and asthma, are available in different mediums now and different languages too, but they can be in the written form, they can be in audio tape, they're also available in illustrated flipbooks. So refer patients to the asthma foundations across the country for those resources. We don't actually have those variety at the NAC, but Asthma Australia do, or Asthma WA. So they're very useful for patients. Here's a couple of examples now. So this is the NAC Asthma Action Plan on the left-hand side, and on the right-hand side is the COPD Action Plan from Lung Foundation Australia. Of course, if our patient has asthma COPD overlap, you would choose the plan depending on the person's dominant clinical features. So both of those plans, as you can clearly see, are color-coded. For green green color is when the patient is well. Orange is when they're starting to feel unwell, and the darker orange when their symptoms are getting worse. And red always indicates emergency, doesn't it? So that's when they will be needing to call an ambulance and they have those real danger signs. But we always hope that if a patient is able to follow their asthma action plan or their COPD action plan, they certainly won't be hopefully getting down into the red zone and needing to call an ambulance if their asthma or COPD is controlled with their treatment. So the key points are that many adults have features of both asthma and COPD. Asthma, COPD, and asthma COPD overlap are all heterogeneous disorders. Patients with asthma COPD overlap are at a higher risk for more serious disease, more symptoms, more flare-ups, a greater need for healthcare utilisation, and unfortunately greater mortality. We can refer our patients to a specialist for atypical symptoms or flare-ups despite treatment, or if they have complex comorbidities. And as I've said now a few times, we manage patients holistically, and it's ongoing management as well. So I'm getting to the topic now of spirometry and asthma, COPD, and COVID. And I know that we're getting back to our GP clinics now, and telehealth is perhaps not being as utilised as what it was certainly down here in Victoria. But it's certainly still helpful if a patient's a little bit hesitant to attend a clinic for fear of catching COVID. But if we're performing spirometry, we need to follow the NAC's recommendations, and we follow the TSANZ or the Thoracic Society of Australia and New Zealand, their recommendations. So at the moment, we're waiting for the latest recommendations to be released from TSANZ. They've been coming for about 3 or 4 months, and they've changed 3 or 4 times throughout COVID. At the moment, however, in primary care, we are running with the August 2021 recommendations, and that is, if there's any community transmission of COVID, spirometry should not be being performed in primary care. So in GP clinics, no spirometry should be performed because there clearly is still community transmission. There's been a few changes, and in, I think it was the middle of January, TSANZ put out preliminary recommendations, but they're not final. So at the NAC, we spoke with our colleagues and our guidelines committee, our committee of respiratory experts, and discussed things with the Lung Foundation Australia as well. And until we get complete final recommendations from TSANZ that say spirometry can be performed in primary care, we are just saying no. And I know that that's very difficult because, you know, Mel and I were discussing that so many patients, unfortunately, with asthma or COPD have been affected by COVID. Their lung function isn't great. They need spirometry. But due to the infection control risks, it's just not worth it at the moment. However, this could change within the next week, guys. So please keep your eye on the website there, the Asthma Handbook website. You could also look up TSANZ spirometry infection control recommendations if you wanted to Google that. But as soon as we've had updated recommendations, we will be giving them to you. I'll give you a few tips though on what to expect to do once you can perform spirometry in your setting. I'm just going to read a bit of a list here because it is a bit of a list. Level 1 PPE or greater and physical distancing is still required. So there'll still need to be 1.5 metres in between yourself or your colleagues who are performing the spirometry and between the patient. Level 2 PPE, so N95 masks and droplet and contact precautions, will need to be considered where inline filters are not available. So you all should be preparing to buy inline filters for your spirometry equipment. I dare say that the TSANZ will suggest that spirometry shouldn't be performed without the inline filters. So that means an extra little component to your equipment, your spirometry equipment, but otherwise you certainly should not be performing it. So I'd certainly get onto your the companies that provide you consumables and get some inline filters for your particular specific spirometer. Lung function testing will not be recommended for anyone with a fever, and I assume up in New South Wales, like here in Victoria, patients are being screened before they attend a clinic, so they should be checked to see if they're febrile or not. If they have any respiratory symptoms such as cough, scratchy throat, runny nose, etc., etc., you wouldn't be performing spirometry on those. We always recommend referring to your state government as to their infection control guidelines, because every state is different, but definitely check up with them as well. And the other thing that is very difficult, and one of the main reasons why we decided that we would keep our recommendation as no spirometry at the moment, is that you need to have 4 air exchanges per hour if you're performing spirometry. So as we know, excuse me, spirometry should take a good half hour. If it's to take longer, you would need to be having 4 air exchanges within an hour. So opening the door, opening the window, excuse me, I'm just going to have a sip of my tea. I always get like this towards the end of a webinar. And we found that that's very difficult because, you know, spirometry is an intensive enough procedure. We don't want to make it even longer for the patient, and opening and closing doors isn't always going to be well received. And also, if you could get a HEPA filter or something like that, I don't know if your clinics are going to be able to purchase those, that will definitely be a recommendation as well. I'm strongly suggesting from the TSANZ. So that was a very long version, I'm sorry, but in the short term, until we get these final recommendations, don't perform spirometry in primary care. If a patient for diagnostic reasons needs to go and do lung function testing, they will need to be referred to a hospital, to a lung function lab. But yes, I understand that we all need to recommence spirometry. I need to recommence them in my clinics with my patients, but it's just not quite there yet as to the guidelines being set in stone. Other things with asthma and COPD and COVID, avoid using a nebulizer. Please avoid using nebulizers. Even pre-COVID, nebulizers are nowhere near as good as an MDI and a spacer. MDIs and spacers get about 30% more medication down into the lower airways where it's needed, but particularly during COVID, they're aerosol generating, these nebulizers, so you don't want to increase the risk of spreading COVID germs or other respiratory, infectious respiratory diseases. Other things during COVID, and I know it's becoming less relevant now, advise your patients not to share medications or devices or even spacers. Make sure that they have their medications handy, particularly their SABs, as per their action plans. But yeah, all I can suggest, guys, is keeping an eye on our website. We're going to be notifying PHNs as well when the new recommendations come into play, hopefully soon. So these are just a few of our resources. I think I've mentioned them all now, and a couple of our handles down there. If you are needing anything, please jump onto any of those websites or contact Mel or Charles or Jenny within your PHN, and they'll be happy to show you where to get things or to contact us. These are just our acknowledgements for those of us who contributed to this little webinar. I hope you've all enjoyed. I hope you have all enjoyed it. Here is the QR code. The QR codes have replaced our other links that Mel and the team used to put up for you, and certainly replaced our paper forms. But I really encourage you guys, if you have a moment, please complete the evaluation for us, because our funding, which we only get year to year, depends on your evaluations. Every evaluation is read by myself, and any changes that you suggest are completely taken on board. And it allows me and my team to tailor each of these webinars and face-to-face workshops to your needs. Tell me if you don't think this is relevant. Tell me if you want more of this, if you don't think you want that. Please just take the time. It doesn't take very long at all. It's very short and sweet, and I know that we're all used to QR codes now, so hopefully it's not too onerous for you. Well, that's it, Mel, from me. I'll let you tell me if there's any questions.
There is, Narelle, and I'll just mention that we are being recorded and it will be live on our website from Monday for 2 weeks, and the resources will be included and a copy of this presentation, so you'll be able to access that. So over to the questions. What age would it be useful to start doing spirometry?
Good question. And look, we generally say from the age of 6. Some 6-year-olds will be able to perform spirometry better than a 70-year-old, for instance. So it is very much individualised. It's a very exhaustive process, as I'm sure you know if you've performed spirometry before. So really, no one under the age of 6 would be able to perform it. But yeah, some 6-year-olds might not be able to. Some 50-year-olds might not be able to. But yeah, certainly not under 6 is the short answer.
Okay, and what is the role of antibiotics in COPD?
Oh, it depends. It depends how they present. It depends whether they have an infectious exacerbation. If the GP has asked for a sputum sample to be sent off and that shows that it's been under micro and culture, shows that something's growing, then that would be when the GP would suggest antibiotics. But yeah, probably I was going to give a ratio 50-50 perhaps, but yeah, it just depends if it's an infective exacerbation.
Okay, we've got lots of positive comments, which I'll send through to you, Narelle, after this as well. You may not be able to see the QR code at the moment, but I'll turn on my camera off in a second and it will be back on the screen for you. What SE will the patient have if using the LAMA who has asthma or overlap asthma with CPD?
Usually just the palpitations and that bit of shakiness. So similar to the SABAs, the short-acting beta-agonists, so your Ventolins, your Bricanol. But it's generally a little bit less with the LAMAs or the LABAs than the SABAs because they're so quick-acting, the Ventolins and the Bricanols. They do tend to send the heart racing a little bit more, whereas because of the prolonged effect of the LAMAs and the LABAs, it's not generally as much. But yeah, the slight tremors and the heart palpitations are the main 2 side effects.
Great, thank you. And that was the last one. It was great content tonight. We really appreciate it, Narelle. It's such an important topic, especially at this time. I'm leaving my camera off so you can see the QR code and scan it for you. Once I close the webinar, you'll also be able to, for all the GPs out there that would like RACGP points, I just want you to pop your name in there and your RACGP number as well, and we'll be able to upload your points for you for ACRM and RACGP. Thank you everybody for being here with us tonight. I know it's a busy time out there and with all the things that are going on in our world, so we do really appreciate your time. Stay safe everyone. Thank you, Narelle. Once again, it's always lovely to do a seminar with you. I always enjoy it. And thank you everyone for being here. So good night everyone.
Thanks everyone. Stay safe. Thanks Mel. Good night.
Bye Narelle.